Hello and welcome to my YouTube channel. Continuing our series of surgical emergencies, today we'll be discussing another important topic, and that is upper gastrointestinal hemorrhage. We'll be covering this topic basically to understand what are the different etiological factors which would lead to upper GI hemorrhage. How do you manage a case of upper GI hemorrhage when it comes to you in an emergency department? We would be discussing both the endoscopic as well as surgical management and what are the indications of surgery. And finally, we would also discuss about the risk stratification, which is an important component of managing an upper GI hemorrhage. So let's get started. Just a brief introduction about upper GI hemorrhage. Statistically, if you see world over, different statistical studies have proven that it is one of the commonest surgical emergencies which we encounter in a surgical department. About 100 to 110 cases per 100,000 adults per year is the incidence of upper GI hemorrhage. And this includes, mind you, both variceal as well as non-variceal hemorrhages. The mortality still remains slightly higher compared to other GI emergencies. Mortality, again, different statistical studies have shown to about 14 to 15%. Increasing mortality and morbidity would occur with increasing age of the patient. That means as the age increases, the mortality and the morbidity would keep on increasing. Now, in a today's scenario, in today's world, surgical intervention has been reduced substantially in managing a case of upper GI hemorrhage, and most of the cases of upper GI hemorrhage can now be managed. In fact, more than 95% of cases of upper GI hemorrhage, which requires any form of intervention, can be managed by endoscopic as well as interventional radiological management. So surgery has taken a backseat. Very few cases, less than 5%, would require surgical intervention. And because the endoscopic management plays such an important role, there has to be a close correlation and collaboration between the surgeon and the endoscopist in managing such a scenario. Now, by definition, what is upper GI hemorrhage? So, by anatomically, if you see any bleeding which is occurring proximal to the ligament of Treats, that means any bleeding which occurs proximal to this, the second part of the duodenum, would lead to development of upper GI hemorrhage. Now, fortunately, 70 to 80% of upper GI hemorrhage cases resolve spontaneously. That means they're self limiting. So, if you give a supportive care to such a patient, most of these, more than 82% of the cases, the chances of rebleed remains, but the initial episode may subside with initial supportive care. So, that is one good thing about upper GI hemorrhage. That means it can in majority of cases can subside or stop spontaneously with supportive care. However, about 15 to 20% of cases would still require some sort of intervention. And goal of any therapy, be it endoscopic management, be it interventional radiological management or a surgical management, the main aim of or the main goal of the therapy is to control ongoing hemorrhage. That is takes a priority. And also, we will see later on, the risk of rebleeding is always there. To prevent risk of rebleeding in a patient who has come to you with the initial bleed. So aim is to control the hemorrhage and also to take measures in between to prevent the risk of rebleeding subsequently in the future. The rebleeding risk remains very high. That means any patient who has one episode of upper GI hemorrhage, the risk of rebleeding, depending on time duration, is about 35 to 40%. So that's quite a high percentage of rebleeding cases. Now we'll come to the etiology, or what are the different, this also would include or cover the classification, the etiological classification of upper GI hemorrhage. Now, traditionally, upper GI hemorrhage has been divided into variceal and non-variceal hemorrhages. The non-variceal hemorrhages forms the major chunk of the causative factors for upper GI hemorrhage. They form about 80 to 90% of all causes. Whereas a variceal hemorrhage, which develops in relationship to portal hypertension, could be esophageal varices or gastric varices. We'll discuss about that in more detail. Forms about 10 to 20%. Though variceal hemorrhage, the incidence is less, but they have higher chances of mortality, and more likely the variceal bleed would require more some sort of intervention. That means they are less likely to subside spontaneously with supportive care, and they would require some sort of intervention to control the hemorrhage. Most of the bleeding, especially in a peptic ulcer, like a duodenal ulcer, which is one of the commonest cause, occurs posteriorly. That means the ulcers which are situated posteriorly would lead to bleeding. Now that old age dictum is always there, the anterior ulcers perforate in duodenum and the posterior ulcers bleed. And the bleeding occurs from gastroduodenal artery or one of the branches of gastroduodenal artery, which is present at the base of the duodenal ulcer. Whereas in cases of bleeding gastric ulcer, which is slightly less common as compared to duodenal ulcer, if it is a lesser curve ulcer in a stomach, then the left gastric artery or one of its branches is the source of hemorrhage. And if it is situated along the greater curve of the stomach, then the gastroepiploic arteries or its branches would be the source of hemorrhage. So you must try to remember this. What are the different arteries or its branches which leads to hemorrhage in depending on this anatomical location where they are situated. Now, coming back to the non-varicose bleeding, which we have already seen forms a major bulk of causative factors for upper GI hemorrhage. If we see on this chart, the commonest etiology in the non-varicose bleed are the peptic ulcers or different erosions within the stomach and the duodenum. It could be a gastritis or duodenitis. Together, these two accounts for almost major bulk. That means almost about 45% of cases. Subsequently, we have some lesser common cases or causes of upper GI hemorrhage. One is esophagitis, which forms about 10% of all cases of non-varicose bleed. Then there's a Mallory-Weiss tear. What exactly is Mallory-Weiss tear, which accounts for about 5%? Now, classically, Mallory-Weiss tear occurs when there is a tear, a mucosal tear at the lower part of the esophagus, just near the gastroesophageal junction, posteriorly. And why this tear occur? Because there is an intense retching and vomiting, forceful vomiting, which may occur following a bout of alcohol binge. So, because of this forceful retching and vomiting, the tear occurs in the mucosa posteriorly at the lower one third of the esophagus, just near the gastroesophageal junction, and this would lead to torrential hemorrhage. So it can occur in a patient who has consumed alcohol, and most of the cases, what we used to see during olden times were seen during the weekend. So most of these cases would report to the emergency department during weekend alcohol binge. This is Mallory-Weiss tear, which accounts for about 5%. Then another slightly less common is a Dieulafoy's ulcer, Dieulafoy's lesion, which is nothing but a very prominent submucosal just under the mucosa. On endoscopy, you can see a very prominent arteriole in the stomach, and that can suddenly bleed and cause torrential hemorrhage. And this would account for about 5% of all cases of non-varicose bleed. And then there are certain cases where, in spite of doing all the investigations, we are still not able to find the causative factor which had led to this bleeding, and those would form about 20 to 25% of all cases. So that's a significant number of cases where, in spite of doing all the investigations, we may not be able to find the causation. And that would be labeled as obscure GI hemorrhage or a idiopathic GI hemorrhage. The less common causes, which accounts for less than 5%, are duodenitis. We have already seen gastroesophageal cancer, carcinoma, which can also be one of the, but less than 1%. And very rarer causes of non-varicose hemorrhage would be certain congenital conditions like hereditary telangiectasias or aortoduodenal fistulas or pancreatitis or some angiodysplasias, though it is more common in small bowel. Now, how to differentiate clinically, just broadly, how would when you're taking a history from the patient, what are the important points in the history which would tell you whether you're dealing with a variceal hemorrhage or a non-variceal hemorrhage? Now, a non-variceal hemorrhage may not be a fresh bleed if it is the bleeding is slightly less, and it may because may get acted upon by the acid in the stomach. It may have that typical what we call coffee ground aspirate or coffee ground vomitus, which contains some sort of blood clots also, and it is slightly darkish in color. Whereas a variceal hemorrhage, being a fresh bleeding, would be a more fresher blood. Generally, variceal hemorrhages are painless bleeding. That means there is no abdominal pain most of the cases, whereas non-variceal hemorrhage may be painful, like in cases of duodenal ulcer or gastritis, or may be painless also. Variceal hemorrhage usually presents with hematemesis. Hematemesis is a vomiting of blood, which usually occurs in variceal hemorrhage, whereas non-variceal hemorrhage not only presents with hematemesis, they also presents with melena, which we'll see what is melena. It's a passage of black, tarry, foul-smelling stools in a patient with upper GI hemorrhage. Many of these patients of variceal hemorrhage, more than 90%, may have some hemodynamic instability in the form of hypotension or tachycardia or tachypnea or some sort of shock. And the hematocrit may decrease by more than 30%. That, what does it mean? It means that the volume of the bleeding in variceal hemorrhage may be quite substantial. And we have already seen that variceal hemorrhages are more likely to lead to increasing mortality and morbidity as compared to non-variceal hemorrhage. In non-variceal hemorrhage, depending on volume of the bleeding, the hemodynamic changes may vary. Sometimes, if it is mild, there may not be any hemodynamic instability. Now, because variceal hemorrhage, one of the commonest causes cirrhosis of liver leading to portal hypertension. So, other signs of chronic liver disease would be seen in a patient of variceal hemorrhage, like on examination, there may be spider nevi, there may be gynecomastia, loss of axillary hair, there may be testicular atrophy or ascites. Whereas in non-variceal hemorrhage, there is unlikely to have any signs of chronic liver disease. So, what are the clinical features when a patient comes to you in an emergency department with a history of having vomited blood? What are the important clinical features? Of course, the most important is hematemesis. And when you're taking a history from the patient, you have to ask few important questions. Number one is, what is the volume of the vomitus? That means that would give you roughly how much blood is lost, depending on what is the volume and how many episodes occurred. That is also very important. Similarly, you would like to ask about the color of the vomitus, whether it contains fresh blood, whether it contains coffee ground aspirate. We have already seen that may tell you possibly you're dealing with either a variceal or a non-variceal hemorrhage. You would also like to ask what are the contents of the vomitus, whether it contains partially digested food particles or undigested food particles. You would ask about the passage of black, tarry, foul smelling stools, which is a melena. Why melena occurs? Because as the blood passes down the gut, in a case of substantial upper GI hemorrhage, it gets acted upon by two important things. Number one is the intestinal enzymes, especially in the small intestine, which would break the component in the blood into different subgroups. And as it goes through the large bowel, it gets acted upon by the colonic bacteria, which colonize the large gut. So, because of this, the blood the stools which passes out in a case of upper GI hemorrhage would be black and tarry because of the action of those intestinal enzymes, and they would be foul smelling because they get acted upon by the colonic bacteria and it passes down. Sometimes, in case of torrential upper GI hemorrhage, because of shortened transit time, many of these patients may also present with fresh lower GI bleed or hematochezia. That's why in any patient with a fresh lower GI bleed, upper GI causes has to be excluded by rule. Now, you would also like to know about history of any dizziness or loss of consciousness or any symptoms suggestive of hemodynamic instability. By asking these questions, and if the patient gives it in an affirmative, that means that your patient has lost lot of or significant volume of blood, and your patient may be at a risk of going into a hypovolemic or hemorrhagic shock. And in that case, the prognosis of that patient becomes slightly poorer. So it is one of the important prognostic factors. If the patient says yes, they felt lightheaded or dizzy, or they lost consciousness prior to or during the episode of upper GI hemorrhage. You would also like to ask whether it's a painless or a painful bleeding, whether there is any abdominal pain associated with it, and you would also like to know whether there is any history of NSAID ingestion, alcohol, smoking history, any past history of similar episode of upper GI bleed, any history of coagulopathy, because the upper GI bleed may be a part of a generalized coagulation defect. Coming to a little bit about variceal hemorrhage, the correct term would be an acute variceal bleeding, or AVB in short. It's a common life threatening complication of cirrhosis, chronic liver disease, leading ultimately to portal hypertension and development of varices, esophageal or gastric varices. 70% of bleeding in portal hypertension occurs due to esophageal or gastric varices. That is very important. 40% die in the first episode of bleeding varices. As we have already seen, the mortality in esophageal varices or gastric varices is quite high. Rebleeding risk is also very high as compared to non-variceal hemorrhages, and rebleeding can occur in 50% of survivors within 1 year. And the rebleeding also carries a very significant risk of mortality, which is to the tune of almost 40%. Hematemesis, which is occurring within the last 48 hours, and or ongoing melena with last melanic stool within last 24 hours in a known or suspected case of portal hypertension would be considered as a case of acute variceal bleed. That means there is a hematemesis which is either occurred within the prior 48 hours, 2 days before, plus, or ongoing melena with a last melanic stool within last 24 hours in any patient who is a known case of portal hypertension would be considered as due to acute variceal bleeding unless proven otherwise. Rebleeding is defined as occurring within 6 weeks of the first episode of acute variceal bleed. That means if there is a first bleed occurring now, your patient reports now, and any bleeding occurs within the 6 weeks of this initial episode, it would be labeled as a case of rebleeding. Whereas any bleeding which occurs more than 6 weeks from the index bleeding would be labeled as a past bleeding and not a case of rebleeding. So these terminologies, I hope you have understood. Now, variceal hemorrhage is also defined as active endoscopically when a spurter or a continuous ooze is seen from the esophageal or gastric varus. So we have seen the clinical parameters when to call it acute variceal hemorrhage. Now endoscopically, when you do an endoscopy in such a case, and when you see a bleeding or a spurting esophageal or gastric varices, then you call it as a acute variceal hemorrhage. And when do you say that control has been achieved in a patient once you initiate the management protocols? The control of acute variceal bleed would be defined as cessation of bleeding with hemodynamic stability. And what exactly is hemodynamic stability? Systolic blood pressure more than 90 millimeter of mercury and mean arterial pressure more than 60 millimeter of mercury for at least 48 hours post therapy would be considered as having achieved a complete control of acute variceal bleed. That means you initiate your resuscitative measures and definitive measures, and there is a complete cessation of bleeding with a hemodynamic stability covering these parameters at least for 48 hours following the initiation of therapy. And then you can say that you have been able to control the acute variceal bleed. And we have already seen what is index bleeding. Index bleeding is the first episode of acute variceal bleed. So these are the different terminologies which are used in conjunction with when you talk about acute variceal hemorrhage. Now, there are also endoscopic classifications based on the size of esophageal varices. There are different endoscopic classifications in different geographical locations and centers. The most common ones which we use are the Japanese classification, and of course, one VA trial and Paquet also. Now, in Japanese, the grade one would be an abs. One would be that there are no varices. Grade one would be small straight varices, which does not disappear with insufflation. Grade 2 would be medium varices, which occupy less than one third of the lumen of esophagus. And grade 3 are large varices, which are occupying more than one third of the lumen of esophagus. So that would be grade 1, 2, and 3 according to Japanese. And other ones are corresponding, which we have already seen here. According to US, grade 1 Japanese would be small, grade 2 Japanese would be medium in US, and any grade 3 varices, that means occupying more than one third of the lumen, would be considered as large varices in US classification. These are the endoscopic, you can say, size classifications of esophageal varices. Coming to esophageal and gastric varices, we have already seen the grades of esophageal varices. There is for gastric varices, there is one classification system which is used, and that is Sarin classification. Sarin classification of gastric varices. Sarin classification in gastroesophageal varices, one grade is varices that extend 2 to 5 centimeters below the gastroesophageal junction and are in continuity with esophageal varices. That means the patient already has esophageal varices, and these esophageal varices would extend just 2 to 5 centimeters below the GE junction. That would be Sarin grade 1. Sarin grade 2 would be varices in the cardia or fundus, and again with continuity of esophageal varices. Okay, the grade 2 would be any varices in the fundus of the stomach near the cardia in continuity with esophageal varices would be Sarin grade 2. Okay, and then we have isolated gastric varices. Isolated gastric varices grades 1 and 2, IGV 1 and IGV 2. Isolated gastric varices grade 1 is varices that occur in the fundus. In any absence of esophageal varices would be isolated gastric varices 1. And isolated gastric varices 2 would be any varices that occur in the gastric body, antrum, or pylorus. Those would be 2. Of course, the patient would not have any esophageal varices. So this is a Sarin classification of gastric varices. One part covers when it is in conjunction with esophageal, and one part covers when it is in isolation without any esophageal varices. Gastroesophageal varices can also be labeled as uphill and downhill varices. Uphill varices means they first develop in the lower part of the esophagus and then they extend upwards. Commonly seen in cirrhosis and portal hypertension. They are the commonest ones. Whereas downhill varices are quite rare. They develop in the upper part of the esophagus, which is very rare, and then they extend downwards. And mostly they are seen in a very rare cause of a superior vena cava obstruction. So these are the uphill and downhill varices. Now, this is a diagrammatic representation of the veins, which basically forms the part of the gastroesophageal varices. As you have seen, we have periesophageal and paraesophageal veins, which communicate with the esophageal varices through the wall of the esophagus and the stomach by what is known as perforating branches. And whenever the portal venous pressure rises, the pressure is transmitted through these communicating veins or perforating veins into the varices, leading to their expansion. Now we'll come to the main part of this presentation, and that is once a patient has come to you with a complaint of having vomited blood in an emergency department, as a postgraduate resident or as a medical officer working in an emergency department, how would you manage such a case? Mind you, it's a team management. where there may be an interventionist, there may be a emergency room medical officers trained, the nursing staff, everybody works in tandem to, especially in the cases of a significant upper GI hemorrhage with hemodynamic instability. Just remember the rule of three in the management of upper GI hemorrhage: resuscitate, which always takes priority, medicate, which may occur simultaneously with resuscitation, and finally, once your patient is stable, then go on to do investigation and find out the cause. The first and the most important part is to save the patient's life, prevent mortality, and try to control the hemorrhage and prevent further morbidity. So, in that case, resuscitation takes priority over everything, over your investigations, over your diagnosis. Once your patient is stable, then you can go ahead and do different type of investigations to find the actual cause of the hemorrhage and try to initiate the definitive measures to control that and to prevent the risk of rebleeding. So, if your patient is able to give a history, a quick and a very efficient history, which we have already seen, what are the important points to cover in the history, should be done either from the patient, if he is able to or she is able to give the history, or from the relatives. Followed by a quick physical examination, especially focusing on abdominal examination and on general examination to look for any signs of chronic liver disease. And then, as the patient is being resuscitated, you can send the initial lab values, which are important. So you can take a blood samples for a full blood count, liver function test, a complete liver function test, renal function test, serum electrolytes, coagulation parameter, a complete coagulation profile, and you would also give a blood grouping and cross matching. So these are the important baseline investigations which would you would send immediately from the emergency department as the patient is getting resuscitated simultaneously. A falling hematocrit is a bad sign which would tell you that there is an ongoing hemorrhage. So triaging is also important. Sometimes you may have to triage whether the patient requires immediate intervention if it is a dire emergency, or the patient can be managed initially in emergency and then later on shifted to the ICU. Timing of endoscopy is very important, which we'll discuss. And what are the prognostication? How would you prognosticate? We'll all discuss all these things subsequently in our management. The history and physical examination, we have already, again, just to reiterate, number of episodes of bleeding, volume of blood, color, past episodes, history of alcohol, smoking, NSAID injection, steroid injection, history of any known case of H. pylori infection, which would give you a clue of a diagnosis of peptic ulcer disease, any history of hepatitis B virus and HCV infection, which would point towards a chronic liver disease pathology, any history of coagulopathy, different comorbid conditions like hypertension, respiratory complications, cardiac complications, which may be coexisting with a patient of upper GI hemorrhage and which may also lead to increasing mortality by itself. On when you examine such a patient, a quick examination, important features to look for includes icterus to rule out jaundice, rule out ascites, which would point towards possibly a presence of uh, portal hypertension. Splenomegaly, ascites in a patient of upper GI hemorrhage would be possibly due to cirrhosis leading to portal hypertension unless proven otherwise. Any signs of hepatic encephalopathy like increasing jaundice or flapping tremors, uh, altered sensorium, all these are important parameters to rule out hepatic encephalopathy. Liver enlarged or not, presence of any dilated abdominal, anterior abdominal wall veins, caput medusae, which may point towards, again, portal hypertension. We have already seen what are the important investigations to send. Viral markers would also be required: HBV, THCV, and surface antigen. Now, coming to resuscitation, what are the different ways? So, first, follow the protocol of the basic protocol of ABC. Make the airway clear. The patient may require elective intubation in a massive bleed. especially in an altered mental status. So the intubation tray should always be at hand. Airway should be cleared of any blood clots, any secretions. Otherwise, the patient may go into respiratory collapse. Patient would also require oxygen. By you can give oxygen by depending on what is the status of the patient, either by nasal prongs or face mask, or you can also give a non-rebreather mask. Two large bore IV cannula, size 16, 14, 16 to 18, should be secured. Why two? Because you can resuscitate with IV fluids and blood. The second one would act as an emergency. You can take samples from the second one. So it's always advisable to have a two large bore IV cannula. Initially, pending the availability of blood, start your IV infusion with crystalloids, especially normal saline or a Ringer's lactate, and immediately place a demand for packed RBCs. As soon as the blood comes, infuse packed RBCs to keep the hemoglobin. The aim is to keep the hemoglobin more than 7 gram%. That is the aim. Don't be, one thing I want to clarify is that you should not be too aggressive in resuscitating a patient. The aim is to keep the systolic blood pressure to the range of only about 90 to 100 millimeter. Don't try aggressively to push the blood pressure to more than 100. That can lead to dislodgement and a reverse increasing bleeding. Also, the aim of giving a blood transfusion is to keep the hemoglobin more than 7 gram%. That is the only aim. Don't try to aim for about 10 or 12 in one go. Similarly, a fresh frozen plasma may be required if you suspect coagulopathy. Catheterize the patient. Urine output monitoring is very important. Maintain an hourly urine output of 1 ml per kg. 1 ml per kg. That means a 70 kg person should produce at least 70 ml of urine per hour, ideally, in an ideal situation, which would tell you that renal function is optimal. The bare minimum is 0.5 ml per kg. That means at least 35 ml should be produced in 1 hour. Any urine output less than 0.5 ml per kg per hour would be an indication that kidneys are undergoing ischemic damage and they are at risk of acute renal failure. The insertion of nasogastric tube in a case of upper GI hemorrhage is slightly controversial and depends on center to center. However, it can detect the need for immediate endoscopic hemostasis if a blood is seen from NG tube in a patient of upper GI hemorrhage. Okay, close monitoring in an ICU setting is very important for such cases because situation may change very rapidly over a period of time. Always optimize the comorbid conditions which are present, be it a diabetes or hypertension or any other comorbid condition. They also require optimizing to prevent further morbidity and mortality. And I've already reiterated that systolic pressure should be in the range of 90 to 100 millimeter of mercury and try to keep the pulse rate below 100. Once your patient is stabilized by the measures which we have seen, then the next step would be OGDS or esophagogastroduodenoscopy. The patient should undergo this OGDS within 24 hours of a bleeding episode. And if we feel that there is a substantial hemorrhage ongoing, then preferably it should be done within 12 hours of stabilization and bleeding. Now, OGDS, I think all of you are quite aware that it can be diagnostic, where it would tell you the source, the site of hemorrhage, whether it's an active bleeding or a past bleeding, and you can also take a biopsy if there's a gastric ulcer. You can also do risk stratification on OGDS. And it is also therapeutic. We have already seen that more than 90%, 95% of cases of upper GI hemorrhage can be controlled by OGDS as well as OGDS measures, as well as by interventional radiological measures. The risk stratification is a very important tool in managing a patient of upper GI hemorrhage. Of course, all this would be done once your patient is hemodynamically stable. What is the need for doing a risk stratification? It would predict the overall risk of rebleeding and morbidity in a patient who has come to you with upper GI hemorrhage. We have already seen that the risk of rebleeding is quite high, especially in a variceal hemorrhage as compared to non-variceal hemorrhage. So, as once you have treated a patient of upper GI hemorrhage, your next concern should be whether this patient is at risk of coming back again with the same complaints or rebleeding within 6 weeks. So, to predict that, you must follow certain scoring system. And what are the different scoring systems? We will see one by one. The first one is the Rockall scoring system, which is an initial scoring system. That means pre-endoscopic Rockall, what we call. It is an appropriate tool for assessment prior to endoscopy, pre-endoscopic Rockall. And it is also predictive of death and rebleeding in a patient with ulcers and varices. So we'll see that in detail. And the other score is Glasgow Blatchford score. GBS for short, Glasgow Blatchford score. What exactly is it? It's a pre-endoscopic. That means a patient has come to you, you have stabilized the patient, you have still not done endoscopy, then you can use this score. So it's a pre-endoscopic risk stratification tool that uses clinical and lab variables to predict the need for any clinical intervention in a patient with upper GI bleeding. That's very important. That means the patient has come to you, you have stabilized, you have initiated all the measures, and then you apply this Glasgow Blatchford score, which is a clinical and biochemical score. And based on the score, you would decide whether this patient requires admission and further management endoscopically, or he has no further risk and he can be discharged. That is the relevance of Glasgow Blatchford score. So, what exactly does it contain? As we have seen, it's a clinical as well as biochemical. So, the first clinical biochemical one is the BUN, blood urea nitrogen. And different scoring systems are given according to blood urea nitrogen level as seen in this chart. The second clinical biochemical parameter it would pick is hemoglobin. Any hemoglobin less than 10 would straight away go into GB score of 6. Whereas if it is between 12 and 13, then it is GB1. Clinical parameters are blood pressure, systolic, heart rate, and other markers. Blood pressure, if it is between 100 and 109 millimeters systolic, the score is 1. If it is less than 90 millimeter, the score is 3. If there's a tachycardia more than 100 beats per minute, the score is 1. Other markers are presence of melena, history of syncope, presence of any hepatic disease or cardiac failure, given the scores accordingly. Now, if the Glasgow Blatchford score is 1 or less, say 0, then the patient is at low risk of any complications of upper GI hemorrhage. It's a low risk patient, and such patient can be managed as an outpatient case. Any Glasgow Blatchford score more than 2 requires admission and possibly endoscopic management within 24 hours. These would be considered as high risk cases who are likely to undergo complications, increasing morbidity, and maybe mortality. So, this is a very important scoring system, and this plays a very important role in risk stratification. Coming to Rockall score, we have already seen Rockall score can be done pre-endoscopically also and then following endoscopy, as opposed to GB score, which is pre-endoscopic. Now, Rockall scoring system has different types of scores. The first one is the systolic BP. If it is more than 100 millimeter of mercury and pulse rate is less than 100, then Rockall score is 0. Whereas if the systolic blood pressure is less than 100 millimeter of mercury and pulse rate is more than 100 beats per minute, Rockall score would be 2. Comorbid conditions, if they are present, then you would give Rockall score of 2. If there's a kidney disease or liver failure, then it would be 3. Then comes the endoscopy. Now, endoscopic diagnosis, the highest one is given for any malignancy of upper GI tract. All other diagnoses would be into Rockall score 1. No lesion or Mallory-Weiss tear would be labeled as Rockall score 0. Major stigmata of recent hemorrhage. If there is no major stigmata of recent hemorrhage, or even dark spots, it would be given Rockall score 0. And if you see major stigmata of recent hemorrhage, then you get like sporting vessel or adherent clot, then it would be Rockall score 2. And based on that, you can predict the mortality and the risk of rebleeding. As seen in this, if the Rockall score is 0, the risk of rebleeding is just 5%. Okay, but as the Rockall score keeps on increasing and it goes more than 7 to 8 plus, the risk of rebleeding keeps on increasing to more than 40%. So this is a Rockall scoring system, can be done both pre-endoscopic and post-endoscopic. In endoscopy, you would see the what are the lesion and whether it's active or passive. For bleeding peptic ulcer, we have Forest classification, which is used endoscopically, as seen in this chart. Forest classification has stage 1A, which is a active sporting bleeder, and the risk of rebleeding is almost to the tune of 60 to 100% in such cases. Stage 1B Forest is oozing bleed, and here the risk of rebleeding is 50%. Stage 2A is a non-bleeding but a visible vessel. The risk of rebleeding is 40 to 50%. 2B is adherent clot, risk of rebleeding 20 to 30%. And 2C is a flat spot in ulcer crater, risk of rebleeding is low, 7 to 10%. And Forest classification 3 has got a clean base ulcer with no evidence of any recent or past hemorrhage, and the risk of rebleeding is absolutely less. It's about just 3 to 5%. So this is a Forest grading, a Forest classification of a bleeding peptic ulcer. It also tells you the risk of rebleeding depending on the class of Forest grade. Now, once the resuscitation is done, you have done the risk stratification. Simultaneously, you would also be giving certain pharmacological agents to control the hemorrhage. And the most important one, especially in a upper GI hemorrhage, when it is proven to be due to bleeding peptic ulcer, then you would give PPI infusion, intravenous bolus of omeprazole, 80 milligram, followed by infusion of 8 milligram per hour for at least 48 to 72 hours, should be given to all patients of upper GI hemorrhage, along with resuscitative measures in a patient where the cause of bleeding is due to bleeding peptic ulcer. The aim of this bolus is to keep the intragastric pH to more than 6. And when the intragastric pH is more than 6, this would stabilize the clot and it would prevent further risk of rebleeding in a high risk ulcers. Forest grade, like where there's active bleed or visible vessel or adherent clot. Those are high risk cases according to Forest classification. So this is a very important pharmacological therapy which should be initiated in all patients, especially in a patient where the cause is due to bleeding peptic ulcer. In a patient of a variceal bleed, if it is proven that terlipressin infusion 4 milligram per 24 hours is preferred over the IV bolus injections. You can also give somatostatin or octreotide within 30 minutes of index variceal bleed. For patients with cirrhosis and active variceal bleeding, a broad spectrum antibiotics is absolutely essential because these patients are at risk of undergoing superadded infection and sepsis. So, broad spectrum antibiotic like ceftriaxone, 1 to 2 gram daily, is recommended at least for 5 days before the endoscopic therapy. It should be initiated before endoscopic therapy. Now, this antibiotic is only required when you have a patient of acute variceal bleed and the underlying cause is portal hypertension due to chronic liver disease leading to cirrhosis. Now, what are the different therapeutic interventions which you would be able to do from OGDS or esophagogastroduodenoscopy in a case of bleeding peptic ulcer disease? We have already seen that OGDS or endoscopy should be performed in a stable patient after resuscitation, preferably within 24 hours of a first episode of bleed and within 12 hours of a patient with continued evidence of bleeding. It is mandatory for ulcers with active bleeding or with a non-bleeding visible vessel. We have already again seen that in more than 80 to 90% of cases, it can control the bleeding without a need for any other intervention. Now, what are the different ways in which you can control the bleed endoscopically in a bleeding peptic ulcer? Number one is injection of diluted adrenaline, 1 is to 10,000 diluted adrenaline, zero point 0.5 to 10 ml should be infiltrated in 4 quadrants within 3 millimeter of bleeding site. This is one of the most important measure you can do in a bleeding peptic ulcer. The second one is thermal coagulation, argon coagulation, or mono or bipolar heater probe. This as shown in this diagram, you can see the lesion on the left side in the diagram A, and on coagulation you can see the changes in diagram B. So this is one of the most effective ways of controlling the hemorrhage and the coagulation, and it is more effective than injection of adrenaline if it is done in isolation. The third way in which you can control the hemorrhage is mechanical. That means use of endoclips or hemoclips. And it can be passed through the scope or it can be passed over the scope. So there are two types of clips which we can use: through the scope or over the scope. And these clips or hemoclips or mechanical clips or endoclips, you can apply 3 clips on a visible or a bleeding vessel as shown in the diagram B. And this, if it is combined with adrenaline or other way of controlling the hemorrhage in combination, would lead to a better control and prevent the further risk of rebleeding. You can also use certain topical agents like shown in this diagram, a hemostatic glue or gels or even oxidized cellulose. Basically, it adheres to the site of hemorrhage and leads to, but the chances of rebleeding may be high, and possibly it can be controlled again with other measures. This is, in a nutshell, the management flow chart of bleeding peptic ulcer. We have already seen that, just to recapitulate, if a patient comes to you with a peptic ulcer bleeding, then first you do resuscitation simultaneously, which is airway protection, and keep the systolic blood pressure to about 90 to 100 millimeter. Pulse rate should be less than 100. Initiate blood transfusion to keep the hemoglobin to more than 7 gram, and prothrombin time to almost 10 seconds. Risk stratification should be done by Glasgow Blatchford score. Uh, if it is 0 to 1, discharge from outpatient department. If it is more than 2, hospitalize and start the treatment. Endoscopic examination should be done within 24 hours after resuscitation. If there are high-risk case or high-risk stigmata like bleeding vessel or visible vessel or adherent clot, perform endoscopic hemostasis. Simultaneously start high-dose PPI therapy and perform endoscopic hemostasis, which we have just discussed. If the Forest classification is low risk or low risk stigmata, like a Forest past history of bleeding or just a clean base ulcer, then no need for any endoscopic hemostasis, but just standard dose of PPI therapy patient should be given and discharged. So this is a nutshell a management flow chart of a bleeding peptic ulcer. And this is a summary of a risk stratification, GBS, and pre-endoscopic Rockall score and their interpretation. As shown, GB score 0, low risk; more than 0, high risk, need intervention; more than 8 is always a very bad GB score and requires ICU admission. Pre-endoscopic Rockall score predicts the mortality risk and rebleeding. If it is 0 Rockall score pre-endoscopic, the risk of rebleeding is very less. If it is more than 5, 6, or 7, the risk of rebleeding and mortality is almost to the tune of 45 to 50%. Now, what are the indications of surgery in a patient with bleeding? We have already seen that more than 90 to 95% of cases can be controlled either by endoscopic or interventional radiology. But there may be some few percentage of cases who may have some form of failure of endoscopic management. So, what are the indications of surgery in such cases? The number one is failure of endoscopic therapy. That is a main indication for the patient to undergo surgery. Now, how many times you would try to control the bleeding endoscopically? That means the patient first comes and undergoes endoscopy to control the hemorrhage, but it fails. Then you can again initiate a second chance of doing an endoscopic control. So, two failed attempts at controlling the bleeding because of endoscopy would be an indication for surgery. Hemodynamic instability despite vigorous resuscitation. That means requiring more than 6 units of transfusion within a short span of time. And persistent hemodynamic instability would be another indication for surgical intervention. Recurrent hemorrhage after initial stabilization immediately would be another indication for surgery. Any shock associated with recurrent hemorrhage or hemodynamic instability and continued slow bleeding, if at all, if it occurs with transfusion requirement of more than 3 units per day for at least 48 to 72 hours, would be another indication for open surgery in a patient. And what do you do in a surgical options? Basically, a midline laparotomy is done, upper midline, supraumbilical, and the interior wall of the duodenal bulb is opened as shown in this diagram longitudinally. And the gastroduodenal artery, as shown in this diagram, is oversewn with a 3-point U stitch technique. 3-point U stitch technique, which effectively ligates the main vessel, the superior and inferior stitches, and also the branches, the small branches, the medial stitch would control the small branch like a transverse pancreatic artery, which can also bleed subsequently. So a U type of stitch is given, 3 stitches, superior and inferior for gastroduodenal artery, and the transverse one is for any small vessel or small branches of that, like transverse pancreatic artery. And then the duodenotomy is closed transversely to avoid any narrowing of the lumen. So this is mainly a surgical management. Fortunately, it is not required in most of the cases, only less than 5%. Now, for acute variceal bleed, how would you control? Just a word about that. Initial resuscitation should be done as in case of bleeding peptic ulcer disease. Pharmacotherapy, we have already seen. Start IV terliplacin, octreotide or somatostatin for at least 2 to 5 days. Terliplacin should be given 2 milligram bolus and 1 milligram every 6 hours for at least 5 days. Somatostatin 250 microgram bolus followed by 250 microgram per hour infusion for 5 days. And antibiotics, as we have already seen, should be given patient with cirrhosis. So because bacterial infection is seen in 20% of cirrhotic patients presenting with upper GI hemorrhage. So incidence of sepsis is almost 60% at 2 weeks interval. So in such cases, ceftriaxone or even quinolones should be given to prevent the development of sepsis in patients of acute variceal bleed with cirrhosis. The diagnosis of variceal hemorrhage is considered certain when active bleeding from varix is observed. We have already seen that, or when a sign of recent bleeding, such as white nipple, is observed. Now, how would you manage for endoscopically bleeding from acute variceal hemorrhage? The first and foremost is endoscopic sclerotherapy. Basically, the sclerosants, which could be ethanolamine oleate or sodium tetradicyl sulfate. These are the sclerosants which can be used, which transfuses these sclerosants through endoscopically, either intravaricial, that means within the varices, or paravaricial, that means surrounding the varice. And what it does is it causes sclerotic reaction and obliteration of esophageal varices. Sometimes the risk of rebleeding may occur, which has to be taken care of. Endoscopic variceal band ligation, EVBL. Endoscopic variceal band ligation. That is another thing which should be done in such cases where, as shown in this diagram, the site of bleeding is identified and a contact is made between the ligator and the varix, and then the suction is applied to draw the varix into the ligator lumen, and then this band is released. So this would achieve the hemostasis. So EVBL is one of the important ways of controlling bleeding due to esophageal varices. EVBL is 90% effective in control of bleeding esophageal varices. But however, the risk of rebleeding is always there, about to the tune of 20 to 30%. But it is better than sclerotherapy in controlling the bleeding and risk of rebleeding. Balloon tamponade by three different type of tubes. One is the Linton Nicholas tube, Sengstaken Blackmore tube, or Minnesota tube. These are the three type of tubes which can be used for giving a balloon tamponade, a pressure which, when it inflated, would lead to a compression of the varices, either esophageal varices or gastric varices or both, and that would be an important part of immediate control of the hemorrhage in a bleeding esophageal varices. Here there is an immediate cessation of bleeding, but because there is a pressure is applied because of this tamponade, the risk of esophageal perforation or its ischemic necrosis of the esophagus is quite high if it is not done properly. So this is a balloon tamponade. Commonly used tube, what we are seeing here is a Sengstaken Blackmore tube, which has got a esophageal balloon and a gastric balloon. So when it is inflated, as shown in this diagram, it would give a pressure effect and prevents the immediate bleeding of esophageal or gastric varices. So there would be immediate cessation of bleeding. Interventional radiology, we have already seen, plays a very important role, and one of the important procedure which can be done in a patient of acute variceal bleed is TIPS, or transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic portosystemic shunt, or TIPS for short. Basically, a shunt is created between the portal vein and the hepatic vein, as shown in this diagram, by interventional radiologist, and this would obviate the need for any formal open shunt surgery. So TIPS plays a very important role. We'll see what are the indications of doing TIPS in a patient of acute variceal bleed. The indications of doing a TIPS is a refractory bleeding to any endoscopic or medical therapy. That means first you manage endoscopically or medically, but the bleeding continues in acute variceal bleed. In that person would be a candidate for TIPS. So refractory bleeding. To prevent rebleeding, if the chances of rebleeding are high in acute variceal bleed, to prevent rebleeding, you can do a preemptive placement of TIPS to prevent further rebleeding. And high-risk patients, after control of bleeding, again, you can subject these patients for TIPS. There's another interventional radiological procedure which can be done. Recently, it has come into a vogue, and that is balloon-occluded retrograde transvenous obliteration, BRTO for short. Balloon-occluded retrograde transvenous obliteration. Mainly, they are used to treat gastric varices, and they are more effective. This BRTO is more effective than TIPS in preventing bleeding from gastric varices. The risk stratification in variceal bleed, like peptic ulcer disease, is based on not only the size of the varices, but also endoscopic signs. So the first one is when the hepatic venous pressure gradient is more than 12 millimeter of mercury. That is one. Large varices, any varices more than 5 mm would be considered as a high risk and risk of rebleeding. Any gastric varus which is isolated and situated predominantly in the fundus of the stomach would be considered as a high risk and a risk of bleeding. Any red veil sign on endoscopy, which basically is nothing but a dilated vessel. Child-Pugh score for C in a patient of cirrhosis. Child-Tauquot-Pugh score is used for classifying a patient of cirrhosis. If the score is C, then that patient is also has a risk of rebleeding and further mortality. Any patient with tense ascites, coagulopathy, or sepsis in association with acute variceal bleed would be a high risk case for increasing mortality and morbidity. So these are the risk stratification parameters which are commonly used in variceal bleeding. This is a flow chart for acute variceal bleed. If you see, the first thing which you should do is hemodynamic resuscitation. Use packed RBCs, maintain hemoglobin to 7. Short-term antibiotic prophylaxis for about 5 to 7 days should be given. Once the patient is stabilized, subject the patient immediately to endoscopy. If the esophageal varices are present, then perform one of the measures of controlling the hemorrhage, whether a band ligation or a sclerotherapy. Uh, Say if you perform a variceal ligation, if the bleeding is controlled, then try to do a risk stratification and see if it is a high risk case, then continue the vasoactive drugs and keep a close watch. And if there is any evidence of rebleeding, then you can do a rescue tips. If it is a high risk case on risk stratification, preemptive tips should be offered to the patient once the bleeding is controlled, telling the patient that we have initially controlled your bleeding, but your risk stratification shows that you are a high risk case for subsequent rebleed and increasing morbidity and mortality. So, in such cases, you should be undergoing a procedure known as TIPS. So, that should be offered, which would prevent further chances of rebleeding. If the control of bleeding does not occur with your EBL, say endoscopic band ligation, then you have to do salvage tips. Salvage tips. So, in a nutshell, after doing endoscopic measures of control of hemorrhage, bleeding is controlled. And if it is not a high risk case, then you continue the patients on pharmacotherapy. If it is a high risk case, after risk stratification, then offer the patient a preemptive tips. If the bleeding is not controlled on endoscopic management and patient continues to bleed, then you must do a salvage tips. That is the flow chart for acute variceal esophageal bleeding. With that, we come to the end of this presentation. Thank you for watching. If you want any specific topics to be covered in my channel, please do let me know. And I would like you to please subscribe, share, and like my video. Thank you so much.